Come on, how many are still using a sliding hip screw, a compression hip screw? Really?
It's cheaper, Joe. We're trying to save money for insurance companies.
Yeah, that's a mistake. So I think, Emil did a great job. That's a great talk. It really doesn't make a difference. What makes a difference is our quality of our reduction. He didn't have in there quality of the bone, but I think that influences our outcomes as well. So that's why we're spending these 20 minutes on reduction and not on implants. So I'm going to try to enlighten the group with regards to how, if you can't get it reduced closed, and we don't understand what a perfect reduction is anyway with regards to these fractures, what we can do to affect a better reduction and therefore theoretically a better outcome. So I guess I have to advance these. So Emil went through all the epidemiology, but our goal is to restore basically femoral length, alignment, and rotation. This is not rocket science. And then we need to provide stability so these patients can be mobilized while preserving, of course, the blood supply. We don't want to put a big gash on these people, disrupt all the blood supply to the proximal femur, and then expect it to heal in a timely fashion. The rationale for these goals is that malreductions, malunions, non-unions compromise outcome, and that's like anything else. If you got to operate on something more than once or twice, your outcomes are going to be compromised. This implant cutout, the implants really don't cut out. The fracture doesn't heal because maybe your poor reduction or the disruption of the blood supply, and the implant kind of sits there and then it burrs its way through the proximal femur as the femur shortens. So there's a lot of forces to understand around the proximal femur that makes a reduction difficult or in some cases impossible. The gluteus medius adds to abduction of that proximal fragment. The piriformis, depending upon if it's on the proximal fragment or the distal fragment, can create some external rotation for me. Same thing with the iliopsoas. If that lesser is part of the distal fragment or it's part of the proximal fragment, it'll either flex the fragment or shorten the femur. And then, of course, there's forces down along the distal fragment itself that we have to take into consideration. Again, it can take these forces are what we have to overcome, in a sense, to obtain a sterile reduction or a good reduction and then get it fixed. So most of us, although I was a little surprised by the use of the sliding hip screw still, most of us put these patients on the table, get them to sleep, and pull on their leg in a well-padded foot and take an x-ray. And in most cases, you can go, is there a pointer in there? You can go to something that looks like this to a pretty good reduction. And then we prep and drape the leg, and then we, for most of us, we nail the proximal femur. I do want to caution against if this is going to take a long time, if you do have to do an open reduction in this position, the well leg compartment syndrome is a real thing. If it's going to take you more than 2 hours to get this done, you may want to take that well leg down, allow it to revascularize, and then if you need to put it back up in order to get your x-rays, put it back up. But do pay attention to that, because it'd be a shame to fix somebody's hip and have them wake up with a dead well leg. So an unacceptable reduction, you can go from the closed reduction, pulling on the leg, applying traction, internal rotation, all those things, to what I consider as semi-open. And this is the use of either shank screws, a picador, a bone hook, or some sort of metal object passed through a relatively small incision, as shown here, to allow us to obtain a reduction, in this case, a reverse obliquity proximal femur. Blocking screws we use a lot in the distal femur and, of course, in the tibia. I haven't seen too much of us using blocking screws in the proximal femur. Again, semi-open, you can put a shank screw in. You don't want to get it involved in the medullary canal if you're going to put a nail in. This can help you obtain a better reduction, and then through a relatively small incision, grab those two fragments with a standard reduction forceps or one of the other clamps And now you have a good reduction. You've restored femoral length, alignment, and rotation, and now you're ready to fix the fracture. This is a good example of what happens to me, and it drives me nuts because I think it's kind of difficult to fix. So here you have a pretty unstable proximal intertroch fracture with good significant instability. We've applied axial traction. I'm not thrilled with that reduction, but it's better than it was. But then when you look on the lateral, you see this, and that, I hate that. That drives me nuts. It drives me nuts because it's difficult, I think, in my hands to correct that. I have tried a host of different things, the old crutch under the distal fragment and the assistant pushing up and trying to push down. What I've developed a real liking for is to slide something across through a relatively small incision, slide something across the femoral neck, the very distal aspect of the femoral neck, reduce that to the shaft, and then put your guide wire in. So you can take something that looked like that on the other side, something that looks like this. That's unacceptable, and Emil showed a terrible case where it actually healed, but it looked like crap. To get it reduced and then put in your nail, and hopefully, if you put it in right and things are stable, it stays there and heals there. That's much prettier than leaving it displaced. You can often get that spiral blade in or the compression screw in that position, but the patient's more than likely going to go on to a non-union and have some compromised outcome. So there's a lot of different approaches to the hip. We're not going to focus on a medial, an anterior, or a posterior approach. To do an open reduction of intertroch fractures, pretty much lateral. You go through the skin, you go through the fascia overlying the gluteus maximus, the tensor fascia lata, and then you work your way. I don't take down the vastus lateralis, but you can work posterior, anterior to it, or slide something along the distal portion of the femoral neck to help get your reduction. So it's pretty much lateral. This is not rocket science. There are a host of different clamps I use to get the reduction when I'm not happy with just a closed reduction. I think the collinear reduction clamp is a wonderful advent, not only for the reverse obliquity fractures, which is like almost orgasmic when it works. It's good for a lot of different fracture patterns. So if you don't have one in your hospital, you probably should reach out to the manufacturer, see if you can get you one. The standard reduction forceps for Bruges or pointed reductions also come in handy, depending on the fracture pattern. There's a couple other techniques we can use, certainly less commonly. Here's an example of putting a shank screw in that proximal fragment, putting a standard reduction forceps on it, a little lateral plate. Usually try to keep these screws intercortical so they're not going across the medullary canal and don't block your nailing, or, well, I guess you'd be nailing at this point. But here's a nice example, extra cortical screws here. Don't get in the way. You put your guide wire in and slip your nail in after a good reduction. Here's an example. You can actually go back in the literature. There's a paper from 1953 where surgeons were struggling with intertrochs. This might be images from that paper. But here's, again, a small plate, unicortical screws just to kind of hold the reduction, get the nail in, and miraculously the nail actually improved the reduction and got good stable fixation. So you have to use a combination at times, but whatever you have to do to get the reduction, because as Emil showed, a good reduction, stable fixation allows these patients to recover better. Starting point's a very important issue. Most of us start at the tip. There's some good literature that shows that's a good place, at least in subtroch fractures. There's other literature that I'm familiar with based on the fact that this was done at WashU that shows there's not an ideal spot, that the anatomy is different. Personally, I think if you get the fracture reduced, there's an ideal spot. Don't be too medial, don't be too lateral. Put it at the tip, or try to start at the tip of the greater trochanter. There are a bunch of complications that we've seen with Emil's talk. I think majority of those complications are related to a poor reduction as well as the bone quality. So in summary, attention to detail, as Kyle pointed out with the treatment of acetabular fractures, restore length, alignment, and rotation, understand the personality of fracture and the soft tissues that are making it difficult for you to get a reduction, and then use multiple reduction techniques. Start with a closed reduction, then a semi-open reduction, and if you have to, open it up, grab hold of those fragments, reduce them, and then fix them. Thank you.